looking mainly at the management of pediatric lymphomas. So in pediatrics, we always have this dictum saying that children are not small adults. Similarly, pediatric lymphomas are very different from the adult lymphomas, mainly in their behavior. Hence, the treatments are also slightly different. So I'd like to take you through the pediatric lymphomas. So in this presentation, we'd be mainly looking at the classification of pediatric lymphomas, and we'll be focusing mainly on Hodgkin and non-Hodgkin lymphoma. It'll be more of an overview. And as we go through each diagnosis, I'll be telling you what's the role of nuclear medicine in management of each of these individual conditions, when to order a PET-CT, and what to order. So as we all know, lymphomas are generally divided into Hodgkin lymphoma and non-Hodgkin lymphoma. So under the Hodgkin lymphoma, based on the histology, we call it either classical and non-classical or the non-nodular lymphocyte predominant subtype. So among classical, the most common entity in children is nodular sclerosis, and it is of relevance to us when we do our reassessment. I'll come to it as we go through this. And then comes mixed cellularity, which again has good prognosis. Lymphocyte rich is quite rare in pediatrics. However, if we have lymphocyte depleted type of Hodgkin lymphoma, this is associated with poor prognosis. The other subtype which comes under Hodgkin is the non-classical or the nodular lymphocyte predominant, which is associated with excellent outcomes. So moving on to Hodgkin lymphoma proper, this is a pediatric malignancy with excellent outcomes. So the long-term outcomes, even in those with advanced stage disease or stage 3 and stage 4, exceeds 95% in many studies. And the treatment has always been combined modality with radiation therapy and chemotherapy. But since the outcomes are so good, we have more and more survivors living on maybe 40 to 50 years after completion of their treatment. So the current focus is on how to decrease the treatment-related morbidity in survivors and methods to reduce this. So if we have to know how to treat them, we need to know how to stage them. So the staging of Hodgkin is very simple. Stage 1 is a single lymph node region or one extra lymphatic site. If you have 2 or more lymph node sites, but both are on the same side of the diaphragm, we call it stage 2. Stage 3 is lymph nodes on both sides of the diaphragm, and it may be accompanied by local extra lymphatic extension as well. Stage 4 is diffuse involvement of one or more extra lymphatic organs or sites. So this usually means that you have bone marrow involvement, liver involvement, or lung involvement. But lung, again, effusion alone is usually not enough. Single nodule is not enough. We need diffuse involvement. So more than 3 foci independently seen in the lung counts as stage 4 for Hodgkin lymphoma. Then we need to know the annotations that we use in Hodgkin. So when we say stage 1A, that means that is only one lymph node region and the patient has no B symptoms. So what are our B symptoms? If we have unexplained weight loss of more than 10% from baseline. So in adults, sometimes we say 5 kg or 6 kg, but children, the baseline weight itself may only be around 20 kilos. So if a 20 kilo child becomes 17 kilos over the span of the last 6 months, that is considered significant weight loss. So we always consider the baseline. And then if we have a weight loss of 10%, that is taken as B symptom. If there is recurrent unexplained fever of more than 38 degrees Celsius, that is considered as febrile and B symptom. Rather than some of them they're tending to say feels warm, but there is no documented temperature. And if they have recurrent night sweats, that's taken as a B symptom. So the other annotation that we commonly see is a bulky tumor. So that is annotated as X, and a single mass which exceeds 10 centimeter in the largest diameter, or a mediastinal mass which exceeds 1/3 of the maximum transverse transthoracic diameter. That is counted as bulky tumor. So it is not of as much relevance as an adult Hodgkin lymphoma. However, it is good to know. We'll come to the relevance later. So one peculiarity about pediatric Hodgkin lymphoma is isolated abdominal disease is a little uncommon. So if we have a child who has come with only abdominal lymph nodes, this is a little less likely to be Hodgkin, whereas isolated thoracic masses, and that too asymptomatic, because this is a very slow growing tumor, is very commonly a presentation of pediatric Hodgkin lymphoma. Moving on to the treatment stratification, because that all our further treatment will be based on what stage do they come in. So if they come under stage 1, which can be 1A or 1B, and up to 2A, they're called treatment limb 1 or treatment level 1. So if in treatment level 1 if they have an ESR at presentation of more than 30, or if they have a bulk of disease which is more than 200 ml, or any extranodal lesions, they will be upgraded to the next level, which is treatment level 2. I hope that's clear. So 1A, 1B, 2A without either an ESR which is elevated, a bulk which is less than 200, and no E lesions will be considered as treatment level 1. Anybody who has ESR which is elevated, bulk which is more than 200, or extranodal lesions go into treatment level 2. Treatment level 2 without any of these is just 2B and 3A. 3B upwards and 2B and 3A with ESR which is elevated or bulk lesion and E lesions will go to treatment level 3. So treatment level 1 is considered early stage. So we follow Euronet PHL. Most pediatric centers usually follow Euronet PHL. The reason for that is that, like we said before, in pediatric Hodgkin, because the outcomes are so good, the survivors tend to have a lot of sequelae if treated very aggressively. So here, treatment is actually based on PET. So we always do an upfront PET-CT so that we are aware of where all the initial disease is. And once we know for sure that this patient only has 1A, 1B, or 2A, they'll fall under treatment level 1. So these patients get 2 cycles of OEPA. This is quite intensive. OEPA is an acronym of all the medicines that is used. O is oncovin or vincristine, E is etoposide, P is prednisolone, and A is adriamycin. So all patients get 2 cycles of OEPA. These cycles take it's 15 days of treatment followed by a 2-week gap. So from the second cycle of OEPA, 2 weeks later, we do a reassessment PET-CT. And in that PET-CT, if they have got adequate response. So this PET-CT is called a IPET or an interim PET, or also called a early response assessment PET. In that, if the response is adequate, they get only 1 cycle of COPDAC, and that is the end of treatment. If there is residual disease, these patients get radiation to the area which has not responded adequately, not to all the involved areas which were initially involved, only the areas which have not got adequate response, and then they are kept on serial follow-up. So it's a very brief treatment and not very intensive. Only this OEPA is intensive. COPDAC is quite light, so to say. Okay, so this is for treatment level 1. Then treatment level 2 and 3. So again, they all get a baseline PET so that we are able to do a interim PET or a early response assessment PET. They again get the same 2 OEPAs, at the end of which we do the reassessment. If reassessment shows appropriate response or adequate response, up to DS3 is considered adequate response actually. So if they have responded adequately, treatment level 2 gets 2 cycles of COPDAC, and that is end of treatment for them. Treatment level 3 will get 4 cycles of COPDAC, and that is end of treatment for them. So if the ERA or the early response assessment shows inadequate response, then we make a decision that at the end of the subsequent 2 more cycles or 4 more cycles of chemo, we will give them radiotherapy, which will be given only to the areas which had inadequate response. However, this decision to do a radiation will also be preceded by what we call a planning PET, and we would like to see that there is no residual disease. At the end of 4 cycles of chemo or 2 cycles of chemo, based on the treatment levels, when we do the PET, if there is any progression, we are supposed to do a biopsy. If that still shows disease regression, the areas which had inadequate response at our IPET or our interim PET will get radiotherapy. So I spoke a lot about the toxicities, and that's why we have cut short on the intensity. What are the common long-term toxicities that we come across in these patients? Cardiac toxicity is one of the most common toxicities that we come across in these patients. This is due to anthracyclines as well as RT. Anthracyclines, we are all aware, can have dose-dependent or idiosyncratic toxicities. So even 2 doses of anthracyclines may be enough to cause cardiac dysfunction. This may be picked up on an echo. However, when we add on the toxicity of RT as well, there is a risk of early atherosclerosis. And for this reason, we need to keep all these patients who have got any dose of anthracyclines on serial monitoring and tell them that they need to be aware of this risk of early atherosclerosis. So to make appropriate lifestyle changes, monitor their BP regularly, monitor lipids regularly, and exercise regularly. These patients who have got anthracyclines have also been noted to have a higher risk of MI as compared to the general population, even without any family history. So, for that reason, with the use of an interim PET, which shows adequate response, we are able to omit radiation, mediastinal radiation, especially in this population of patients who have appropriate response. So, this is a little different from the adult Hodgkin management. In adult Hodgkin, remember our annotation of X, which has bulky disease. Anybody who has got a lymph node which is large, irrespective of what their response is, they get RT because their bulk disease has been known to be associated with increased risk of relapse. So this is where pediatric studies are slightly different. So we like to avoid RT as much as possible for the risk of cardiac toxicity, for the avoiding the risk of pulmonary toxicity. So for that reason, even if they had bulk disease to start with, if the PET at the interim response assessment shows no avid disease, we avoid RT to the mediastinum. Similarly, remember we said that the common histology that we see in pediatric Hodgkin is nodular sclerosis. So nodular sclerosis is slightly different from the other uh, histologies in that even when the disease responds to therapy, they actually do not have a reduction in mass. So a reduction in avidity is enough. So if we had used only a CT scan for reassessment, we would end up irradiating this population unnecessarily. Whereas once we have done a PET and we know that it is non-avid, we do not need to irradiate them, thereby preventing the long-term sequelae. The other important thing where pediatric Hodgkin treatment is different from the adult Hodgkin treatment is most adult protocols have a lot of bleomycin. ABVD is the common protocol that they employ, and that B in that is bleomycin. So, in a pediatric population, when we give so much of bleomycin, there is a theoretical possibility of pulmonary toxicity in the long run, especially the uh, higher risk groups, so to say, where you get up to 6 cycles of ABD. So by giving OEPA with COPDAC, we are avoiding bleomycin. Similarly, in this cohort, these are a young population. We would like to avoid gonadal toxicity as much as possible. So earlier protocols used to use COP and COP has procarbazine, whereas nowadays we prefer to use COP-DAC, where the procarbazine is substituted by with dacarbazine. So that reduces the gonadal toxicity and the overall exposure to cyclophosphamide is also reduced in the pediatric protocols, thereby preserving fertility. So the therapeutic agents implicated in long-term sequelae, as we have mentioned, are anthracyclines, bleomycin, cyclophosphamide procarb, and meclorethamine for gonadal toxicity. And RT, especially mediastinal, has been implicated in cardiac dysfunction as well as breast malignancies in young women. So that is why all these protocols have attempted to decrease the overall exposure to these agents. And currently, what we follow is uronate PHL protocol, where the main consideration is to avoid RT in those who have adequate response at the first restaging, and procarbazine has been replaced with dacarbazine. And by using OEPA, which has adriamycin only in the first 2 cycles, we have also reduced the overall exposure to anthracyclines. So with all these measures still, the outcomes in pediatric Hodgkin lymphoma is excellent. As you can see, the line actually does not dip beyond 90 even at more than 5 years from the start of treatment. So because they are such good outcomes, even with with reduction of the intensity of treatment is why pediatric protocols are less intensive. So now we move on to the other subset of Hodgkin, which is called nodular lymphocyte predominant Hodgkin. So nodular lymphocyte predominant Hodgkin lymphoma is actually got excellent outcomes. So if the diagnostic biopsy confirms nodular lymphocyte predominant Hodgkin, we do a staging, which is ideally with PET-CT. And in that, if the disease is 1A, which is limited to only one stage, we see whether we can surgically remove this. If surgically this patient can be completely resected, then we keep them on follow-up. Complete resection is not possible. We offer either additional surgery after giving a little bit of chemotherapy. But if complete resection is possible, that is the treatment of choice. We don't need to expose these children to either chemotherapy or radiotherapy. If 1A disease, which is not completely resectable, is possible in an area which is not So usually neck tumors, we prefer not to irradiate early in children because of implications to thyroid and mediastinal masses. Also, obviously, we would not irradiate early. But if it is inguinal lesion or something where radiation is not going to be very harmful, we do offer RT to stage 1A, which is not completely resectable. Anything where resection may be difficult up to 2A, they get only 3 cycles of CVP. Now, CVP is like a very light chemotherapy where you only give cyclophosphamide, vinblastine, and prednisolone. There is hardly any cytopenias, not much of nausea, and 3 cycles of CVP usually means that treatment gets over in 9 weeks' time. And at that point in time, when we do a reassessment PET, if the response is good, we just keep them under follow-up. If at that point in time they have poor response, then we need to upstage and give them more intensive therapy. So what does intensive therapy mean? In any patient with nodular lymphocyte predominant Hodgkin who has a stage of 2B or above, or has extranodal involvement, or those who have inadequate response to CVP. And in addition to this, if histological patterns show pattern D, E. These are markers of aggressive behavior. We offer them RABVD. What is RABVD? R is nothing but rituximab. So NLPHL universally usually expresses CD20. So we utilize the monoclonal antibody against CD20, which is rituximab. In addition, we give them ABVD. ABVD is what we commonly follow in adult Hodgkin lymphoma protocols: adriamycin, bleo, vinblastine, and dacarbazine. So here the number of cycles that we give will be based on the stage. Up to 3A will get 3 cycles of RABVD, and beyond will get 6 cycles of RABVD. RABVD is a little difficult at time in the sense that the Ritux goes at 3 weekly intervals. ABVD happens at 2 weekly intervals. So one ABVD will have day 1 of chemo and day 15 of chemo. So the timing is a little difficult, but if we write it down carefully and we stage them appropriately, treatment is easy. So now we move on to the next part of the talk, which is on non-Hodgkin lymphoma. So pediatric non-Hodgkin lymphoma, we stage them first based on, is it a precursor lymphoma or a mature lymphoma? Precursor lymphomas are the lymphoblastic lymphomas, which is either T lymphoblastic or B lymphoblastic. The mature lymphomas, we divide them based on the lineage again, B cell lymphomas and T cell lymphomas. Among the B cell lymphomas, the most common ones that we get are Burkitt lymphoma, followed by DLBCL, followed by primary mediastinal B-cell lymphoma. This is usually more of a disease of young adolescents and young adults, less than 30 years of age. Then we have pediatric follicular lymphoma, which is very rare, and pediatric nodal marginal zone lymphoma. To be honest, I have come across maybe one of these in all these years, so we'll not be looking mainly at this. Our focus will on in this day will be mainly on Burkitt, DLBCL, and primary mediastinal B-cell lymphoma. T-cell, again, we divided mainly into anaplastic large cell lymphoma and peripheral T cell lymphoma NOS. Our focus again today will only be on ALCL because PTCL NOS is a little different. However, we do treat it among the lines of adult lymphomas. So lymphoblastic lymphomas, as the name suggests, are immature lymphomas. The name blastic means immature, essentially. So these patients may present with lymphadenopathy. They may present with mediastinal masses. Occasionally, they may present with renal masses or just isolated hypertension. When it is evaluated, may reveal the diagnosis of a lymphoblastic lymphoma. When you call it a lymphoblastic lymphoma, the bone marrow involvement has to be less than 20%. Anything more than 20%, we do call it as a lymphoblastic leukemia. And then either way, the treatment is on ALL protocol, but our reassessment will differ. So how do you treat these patients? So it is a slightly long treatment. So we induce remission using drugs such as steroid, which can be either prednisolone or dexamethasone, vincristine and asparaginase, and daunorubicin. Once remission is induced, we go on to consolidate that remission that we have achieved. Here the main drugs are cyclophosphamide, cytosine, asparaginase, and vincristine along with 6-MP. So if it is a lymphoma, our reassessment happens after consolidation. So 2 cycles of chemotherapy and then we reassess. If the disease is non-evident at this point, we go ahead with the remaining treatment, which is interim maintenance, which is mainly prophylaxis against the CNS relapse using methotrexate and delayed intensification. And following this, all protocols nowadays give 2 years of maintenance therapy. 2 years of maintenance therapy is usually mostly oral medications Some protocols may add vincristine monthly to this, especially in lymphoblastic lymphomas, because we know biologically this is more aggressive a disease as compared to pediatric leukemias. But essentially, treatment is for 2.5 to 3 years total duration. And among this, intensive chemo is all the way till the part which says delayed intensification. So we induce remission, we consolidate what we achieve, then we go on to a slight interim maintenance where the focus is mainly on CNS prophylaxis. We intensify therapy once more, and the drugs will be similar to our induction and consolidation drugs. Following this, we put them on maintenance therapy for 2 years, and that is the end of treatment for these children. Again, remember, lymphoblastic lymphomas, especially T lymphoblastic lymphomas, our reassessment happens at this point or after consolidation. And if they are PET non-avid, we try to omit radiotherapy. So outcomes in TLBL in Western literature especially has been progressively improving over years. So maybe 2 decades ago, we would have said outcomes of 50 to 60%. Nowadays, with the advent of newer drugs, our outcomes are reaching up to 80%. So one thing that I would like to note on this graph before we move on is that the initial dip happens within 1 year of diagnosis. Most TLBLs have this propensity where if you make it through the first year without relapse, most of the time you will be okay beyond that. So focus is initially on getting them into remission. Beyond that, we know that we'll mostly be okay. BLBL or B lymphoblastic lymphoma has actually got better outcomes than T, but BLBL usually has more propensity to present with renal involvement as compared to TLBL. TLBL has this propensity to present with mediastinal masses, pericardial effusion, etc. A little more propensity as compared to TLBL. This graph that we see here is actually data from an Indian tertiary cancer center. This is from TMC. So we can see that even Indian outcomes are almost at 80%. But in B, if you look at the graph, the relapse can occur anywhere till 5 years. This is censored at 60 months or roughly 5 years. So unlike T, your B can relapse a little later also. So we need to keep them on more closer follow-up, and end of 1 year of treatment does not really give you much relief. We need to watch till 5 years of treatment. Moving on to the mature BNHLs in children. The most common mature BNHL is Burkitt lymphoma, followed by DLBCL. A small fraction of adolescents may have primary mediastinal large B-cell lymphoma or PMBCL as we call it. The rare NHLs, I will not be talking about this time because they're indeed very rare. So Burkitt was first described in 1958 by Dr. Dennis Burkitt while working in Africa. So he came across this set of children who had large jaw masses, and he called it as a sarcoma of the jaw. And this was at that point the commonest cause of cancer in Africa. So Burkitt has the notoriety of being the first tumor to be associated with virus, EBV, and the first to be associated with recurrent chromosomal translocations, which is a MIC rearrangements. And it is also known to be the first lymphoma which is told to be associated with HIV. With increasing prevalence of HIV, Burkitt has also been seen very commonly among the adult population. So DLBCL and Burkitt lymphoma, both are mature B lymphomas, but they do have certain differences. So in pediatric Burkitt lymphoma, the DLBCL usually has a higher male preponderance, and the median age is also slightly higher as compared to Burkitt. And usually DLBCL presents at a lower stage. Usually most of the patients will have either stage 2 or stage 3 disease. Whereas if you look at the Burkitt cohort, usually they all present with advanced disease, stage 3 or stage 4. Marrow involvement is quite common in Burkitt as against DLBCL, where marrow involvement is very rare. Similarly, CNS involvement is also higher in the Burkitt group. Mediastinal involvement, however, is not very common in Burkitt lymphoma. So if you have a child with a mediastinal mass which is progressing quite rapidly, slow growing mediastinal tumor, Hodgkin, rapidly growing mediastinal tumor, either the lymphoblastic lymphomas or DLBCL, that will be your thought process in children. B symptoms are quite common in Burkitt lymphomas, and LDH is usually markedly high because this is a rapidly proliferating or a rapid turnover tumor, so to say. All Burkitt lymphomas have to have c-MYC gene rearrangements, whereas DLBCLs very rarely expects c-MYC gene rearrangements. Now, the immunophenotype, where you to run an immunophenotype on DLBCL and Burkitt, both of these will strongly express CD20 and CD19. This is a mark of differentiation. Our lymphoblastic lymphomas usually will not express CD20, whereas our DLBCL and Burkitt will strongly express CD20, and both of them will lack TDT. TDT is a marker of immaturity, so that will be seen in lymphoblastic lymphoma, and both will have high Ki67 indices. This is a mark of high proliferation. So Burkitt, typically we say, will have almost 100% Ki67 or a MIB index, whereas DLBCL will have somewhere around up to 95% expression of Ki67. And both BCL2 is more likely to be expressed seen in DLBCL. So for confirmation of diagnosis, we need the morphology, which is the starry sky appearance that we are aware of, and we need the cytogenetics, which shows c-MYC rearrangement in Burkitt, and immunophenotyping, which, as we mentioned before, will usually show CD20 positive along with immunoglobulin expression. BCL6 may be positive, and TDT should be negative. So there is a lot of confusion about the other types of lymphoma because this is mostly based on morphology and immunophenotype. So there is a little bit of overlap, as you can see. So the classic Burkitt will have CD19, CD20. They usually have a lot of immunoglobulin rearrangements. And remember, Ki67 of 100% essentially means Burkitt. Slightly lower Ki67 will be DLBCL. Then if the classic morphology is present, but the c-MYC expression is absent, that makes it Burkitt-like or atypical Burkitt. However, these three will get treated on the same protocol. So morphology may be slightly different. Your antigen expressions and c-MYC, rearrangements may be different. However, the treatment remains the same. Now, there is this entity of classic Hodgkin where you can have CD30 expression and CD20 expression in 20 to 30. So CD20 expression sometimes may be present. This is usually more of NLPHL, though very rarely this can be seen in classic Hodgkin also. When you have CD30 expression and CD20 expression, but without a surface immunoglobulin, that makes you think in terms of primary mediastinal large B-cell lymphoma. Here, it is important to remember this surface immunoglobulin is absent, and for that reason, a treatment is also different from this cohort of Burkitt, DLBCL, or atypical Burkitt. So the staging here is a little different from our Hodgkin. Stage 1 is essentially a single tumor, which the exclusion of a mediastinal tumor or an abdominal tumor. You have a single cervical lymph node that comes here. If you have an abdominal tumor, however, it falls in the stage 2 group. Stage 2 is a single tumor with regional involvement or 2 or more nodal involvement on the same side of diaphragm, and a primary GI tract tumor without any involvement of associated intra-abdominal lymphadenopathy, which has been completely resected, will come here. If it has not been completely resected, it goes to stage 3. Again, paraspinal or epidural tumors will come under stage 3. Stage 4 is if there is marrow involvement of more than 25% or there is CNS involvement. So treatment for Burkitt, remember we said they are fast growing tumors, so we need aggressive therapy as well. So the pre-phase or COP is a cytoreduction. So after the cytoreduction, we move on to copadam, which is again quite intensive therapy. 2 cycles of copadam. If they are stage 3, then they get 2 cycles of SIM, and then that is the end of treatment. So the reassessment happens at this point after SIM. For group C, which is essentially stage 4 disease, we have to give a little bit more treatment. So after this copadam, they get 2 cycles of Cy, which includes high dose cytosine, and then they get 2 cycles of maintenance as well. So reassessment. So if it is up to group B, we give pre-phase, which for cytoreduction, copadam 2, SIM 1, and reassessment happens here. If that shows no avid disease, that is just SIM 2 and end of treatment. If reassessment shows avid disease, then we have to do a surgical excision. If that does not show any disease, again, it is only SIM 2. If that shows any residual disease, we upstage them to the next group, which is group C, and we intensify therapy further with further chemotherapy. This is group C, pre-phase copadam, followed by R-Cyve into 2. Here, the reassessment can happen either here or here. Most people prefer to do it just before commencement of maintenance. One thing I would like you to note is all high risk Burkitt bar DLB, all Burkitt get Ritux, all high risk DLBSL also. Usually we tend to give Ritux. Once we give Ritux, there is further intensification. So the drug doses are usually reduced to decrease infection associated morbidity and mortality. So what we have come to realize is Burkitt up to C1, where there's no CNS involvement, outcomes are pretty good, almost 85%. Once there is CNS involvement, the outcomes come down a bit. But even then, for a lymphoma, this is fantastic results. So if we can get through the initial treatment without much tumor lysis and infection-associated mortality, outcomes are excellent. So we always advocate for treatment of these patients. So here again, the results show that outcomes are better than 80%, especially in the pediatric subgroup. So, like I had mentioned before, because of these increased toxicity with addition of rituximab, people tend to decrease the doses of the other chemotherapy drugs that we have given so as to decrease the infection-associated morbidity and mortality. So just a short note on primary mediastinal B-cell lymphoma. It's not very commonly seen in children, but like the name indicates, the disease is primarily located in the mediastinum. The tumor is, however, quite aggressive. A lot of them present with thrombosis of the large vessels and even pericardial infiltration. So the treatment is very intensive. We try to give them every 2 weekly with R-CHOP or R dosages report, where you try to intensify treatment based on what is maximally tolerated, and this happens every 3 weekly. At the end of 3 cycles of chemotherapy, we reassess. If that reassessment shows good response, then they get only 3 more cycles of chemotherapy, and that is end of treatment. This tumor is exquisitely radiosensitive. So even though it is a mediastinal mass, because the radiotherapy sensitivity is quite high, we do offer radiotherapy for those who have got less or suboptimal response. If at the end of 6 cycles there is still residual disease, we need to do a biopsy, because remember the diagram that we saw earlier, it could have been any of the other malignancies which we had maybe not picked up due to inadequate sampling. Thoracic masses are difficult to sample, so we need to re-establish the diagnosis by repeating a biopsy and then go on to salvage therapy. The last diagnosis that we'll be discussing today would be anaplastic large cell lymphoma. This is a rare form of TNHL. All that we had discussed so far are mature B cell lymphomas. This is a TNHL, and it accounts for about 10 to 15% of childhood lymphomas. As the name suggests, these are large pleomorphic cells, and they almost universally express CD30. So, ALK positive ALCL is more commonly seen in children. Almost 95% of this cohort would be ALK positive, and they express anaplastic lymphoma kinase or ALK, and this is the driver of tumorigenesis in ALK positive ALCL. This is in comparison to adult ALCL, where only around half of the ALCLs will express ALK, and the rest will be ALK negative. And as we can understand from this, ALK positivity usually implies better response to treatment. So here the definition of organ involvement is a little different, because these patients may have extranodal involvement alone sometimes, and skin involvement should always be confirmed by biopsy. Looking at it morphologically is not enough. Mediastinal involvement can be confirmed by cross-sectional imaging. We don't need a biopsy if there is cross-sectional imaging. Liver involvement, even clinically enlarged liver is enough. We do not have uptake, and liver being nodular on imaging is sufficient. Similarly for spleen. And lung involvement, again, multifocal involvement is commonly seen. Bone involvement is quite commonly seen in ALCL, which is a peculiarity of this disease. And CNS involvement can be proven either by the presence of lymphoma cells or detecting the translocation that we had mentioned. And anybody who has got a cranial nerve palsy is taken as CNS involvement. So this is the staging, that it is quite similar to the BNHL staging that we had followed. So the implications of classifying is quite important. So if we have isolated skin lesions, we only wait and watch. We do not treat them. In low risk disease or stage 1 disease, which has been completely resected, it is very light chemo with only 3 cycles of chemo. Standard risk disease is all other than skin involvement. Mediastinal disease, lung involvement, liver and spleen involvement makes it high risk, and CNS disease obviously gets a higher degree of treatment. So if it is isolated skin involvement, excision may be enough and we wait and watch. So if it is an extensive plaque which is not amenable to excision, some people offer local therapy. And with stage 1 completely resected disease, we offer only cytoreduction. The preface is often not very required here. We give 3 cycles of chemo, and that is end of treatment. All treatment, all patients with CNS involvement get treated similar to what we saw for stage 4 B lymphomas, except that we do not add rituximab here because rituximab is a monoclonal antibody against CD20, which is seen in B lymphomas but not in ALCL. And the rest of the treatment, rest of the patients. So majority of our ALCL patients will come here. They are neither stage 1 nor do they have CNS involvement, and they all get this prephase, which is essentially cyclophosphamide, steroid, and AMBM. So reassessment here is not very standardized. So because it is a biologically a little different disease, there is no specified time point during therapy when CR should be obtained. So obviously, before you end your therapy, we would like to document remission. But even documentation of remission is not very clear in the sense that if there is no increase or progression in disease, we are actually okay to wait and watch. So if the tumor volume has come down to less than 30% of its original size, even if there is some avidity, a lot of protocols say you wait and watch, you don't need to biopsy. If the reduction is to less than 30% of the original size, or if there is obvious progression of disease, then we are supposed to do a repeat biopsy, confirm that there has been no transformation, and offer more aggressive treatment. Uh, I am not talking about relapsed lymphomas here. Relapsed lymphomas, the outcomes are still actually better, especially in Hodgkin lymphoma. Burkitt lymphoma, if it relapses, the outcomes are usually not good. All the other lymphomas, usually based on when they relapse. Early relapses, we give salvage chemotherapy, and we tend to consolidate our remission with an autologous stem cell transplant. Late relapses, because they are still favorable disease, we may just get them into remission with salvage chemo and wait and watch. But important thing in terms of nuclear medicine is to inform the nuclear medicine team what therapy have you given. Because nowadays, with availability of nivolumab, a lot of the salvage protocols include nivolumab, in which case there may be pseudo progression seen at the reassessment imaging. So important to inform them what have you given and to assess the response to treatment. So to conclude, pediatric lymphomas are a spectrum of diverse disorders with varying outcomes. These have much better outcomes as compared to adult lymphomas. Therefore, because they have long-term survivors, the regimens are focused more on preventing long-term sequelae, and risk stratification and disease reassessment at appropriate time points, especially using a PET-CT, helps in identifying the population at risk and intensifying therapy only in those who are at risk, thereby preventing long-term sequelae. Thank you.